images in the media of people running around looking for oxygen. By the time you've got to that situation, you're so far down the road in a given wave in the pandemic that it's almost too late. What we really want to say to people out there and to countries is we've got, even in the absence of enough vaccine, we've just simply got to try and keep up our efforts to do the surveillance and quarantine of cases, to do the contact tracing, to implement basic measures to protect yourself and protect others, whatever you can do. Because in some countries, this pandemic is going in exactly the wrong direction. And I can see that upward turn in Southeast Asia. I can see that upward turn in Europe. I can see that upward turn in the data in the Eastern Mediterranean. Africa is now experiencing more cases today than it ever has at any previous time in the epidemic, and is rapidly heading there in terms of deaths as well. And the Western Pacific area has just flatlined over the last number of weeks. It's really just waiting. It's at a much higher level than previously. So you couldn't say that anywhere in the world is really getting through this or going in the right direction. As I said, the Americas is flat, and it could go back up or down.
It's fragile.
It's very fragile. Yeah, I think you used that word in the beginning. So I think we just need to take stock and reckon. I'm very pleased for those who are being vaccinated. I'm very pleased for those countries that are getting things under control. Don't get me wrong, for those countries that are able to open up their societies a little more, that's fantastic news. But please spare a thought for those people who are living without vaccine, living in countries where it is very difficult to implement the kind of measures to support people in implementing those measures, and they really are falling behind. This has now become a two-tier pandemic. It's a pandemic of the haves and a pandemic of the have-nots, as has been the case in so many other things in the past. It's just sad to see us making the same mistakes over and over.
Can I just comment on something Mike said? When Mike said, we need to be doing the surveillance and the testing, he didn't say lockdown or not. I still think there's a misunderstanding about when we talk about public health and social measures that people hear us say lockdown. It means that you're locked in your homes and you're stuck in your home for long periods of time. It's not what we mean, and it isn't what countries are doing. The successful countries that are implementing a comprehensive strategy, and again, the other thing is it's not one measure alone. It isn't surveillance alone or testing alone or oxygen alone or dexamethasone alone or vaccines alone. It's all of these things in combination. Not all at the same intensity, all at the same time. It's using the tools that we have. And so this notion that you are either completely free to do whatever you want or are in a full lockdown is really a misunderstanding, and it's a false dichotomy. And I think we need to continue to emphasize this, because there are lots of things that you could do yourself. There are lots of policies that need to be in place to keep you protected, but it doesn't mean that you are locked in your home. And I think we just need to reemphasize that, because I still think this is quite a long ways away. And I really am struck by this, Alex. I don't know how Mike feels on this, but what's the right tone to have when we speak? Because we're concerned. We're not alarmist. It's not a fear. It's a concern, because if we don't use the tools that we have, these trajectories that we see will end up having images of hospitals overwhelmed, of ICUs overwhelmed. And when we talk to our regions, we talk to the countries, what we hear is ICU capacity is at 90% or 99%. I don't know how many regions said this to us last week, and said in a number of countries, that's the situation that we're in. And there are things that we can do to prevent us from reaching that level. And it starts with every single person doing what they can to keep themselves safe. It matters what policies are in place at national levels, at subnational levels, but it matters also what we do every single day, because the more infections we can prevent, the more we can prevent that downstream of hospitalizations and ICU and death. And so it's a serious situation that we're in right now.
Thank you both. We are already receiving a lot of follow-up questions on the epidemiological situation in different parts of the world. So one is about the countries that you mentioned in Southeast Asia or some parts of Africa where cases are exponentially growing. Mm-hmm. What do people can do, and especially if they need to provide care at home, if hospitals are full. So maybe we can start with that one, and then I'll read the rest.
Maria can maybe give some more direct information on the guidance we have out there on home care. But in reality, the best place for someone who's got severe COVID-19, particularly with respiratory complications, is in a hospital where there's a qualified doctor or a nurse with the appropriate drugs and with oxygen available to treat them. That's the best. The problem in the system is when you have the system gets clogged up by having so many cases, and some people are unwell but they're going to be fine, and some people are unwell and they're not going to do so fine. And it's really choosing in any given group who are the most at risk of having that really severe desaturation. In other words, having a severe episode where they lose oxygen in their blood. And that means you have to have quite an efficient system. So when you see your primary care physician or you see your primary care nurse, that person has got to be able to decide whether you're high risk for severe disease and then refer you into the system so you can get to the right place to get the right care. The difficulty is when there are so many cases, the system starts to become very inefficient, and then everyone is getting referred everywhere, and the emergency rooms become overwhelmed, and then the doctors and the nurses can't see everybody, and they can't give enough time to decide who needs the intensive care versus who doesn't. So the system itself actually gets overwhelmed. So we would like to see countries invest more in making sure that they have really clear mechanisms for selecting the patients who need to be in hospital. Some patients could end up in hospitals, sometimes in private hospitals, and they're on oxygen and they probably may not need that oxygen. And they're in an intensive care environment but that they may not need. And another patient is sitting down in an emergency room in a public hospital unable to get any care at all, even to get an examination. So the inequities in our systems are being played out. The systems need to be very efficient at doing that. However, there are situations, and we've seen that in the last number of months, where the system is just not able to cope, and families are having to take care of their loved ones at home. And we have issued guidance. We have issued guidance for that. But I would have to say that the best place for a person with severe COVID is in a healthcare facility, being cared for by a qualified physician or nurse with the right equipment and the right drugs and the right tools. However, it is possible to do good supportive care at home, but it is by no means ideal. It's by no means ideal. Maria?
Yeah. So we do recommend, as Mike said, that anyone with severe symptoms seek care immediately. In the situation that you're in, contact your local provider, contact the hotline, go seek care. If you can call ahead if possible. But we do also recommend individuals who have underlying conditions or who are at a higher risk of developing severe disease also to seek care and be cared for in a health facility, because we're worried that they could become very sick very quickly. And so they need to be monitored so that the earlier the care they receive, the better the outcome that they can have. So these are individuals who are above the age of 60 or anyone with underlying medical conditions. And so that's really important. On the other hand, if there are individuals who can be cared at home, so these are people without those risk factors for severe disease, they can be cared for at home safely or as safely as possible, because if we know if someone is at home who is infected with the SARS-CoV-2 virus, they can pass the virus to others. And so it's important that you take measures at home while you're caring for somebody at home. This means isolating the individual. If possible, if you have a separate room with a separate bathroom, that would be ideal, but we know much of the world doesn't have access to that, doesn't have that level of separate facilities in the home. So keep as much as possible the infected person away from others. Make sure that that person is cared for in a well-ventilated room. Open the windows or open 2 windows so that you have the good cross ventilation of fresh air. Make sure that it's safe to do so, to open windows. Make sure that one person in the home, if possible, be assigned to care for that individual so that you minimize the contact with others, that the individual at home is wearing a medical mask, the sick person plus the person caring for them wearing a medical mask. Do everything that you can with clean hands and disinfecting your hands and surfaces. And then monitor them every day. Check on them every day, make sure that they have good food, hydration, and look out for some warning signs. If they have difficulty breathing or if they're confused, seek care immediately. We do make sure that you're in contact with a medical provider if possible. Check the oxygen levels. Sometimes you can get those oxygen saturation machines to check the oxygen saturation level at home if possible. We do advise you have to be very careful about the use of oxygen. We've seen many people try to procure and purchase oxygen and care and give that at home, and that could be very dangerous because these are tanks of oxygen, and we've seen some explosion of those tanks. We have to be careful how they're used. And also I want to just mention steroids, the use of steroids and dexamethasone. So dexamethasone is one of the therapeutics, one of the drugs that we know, if given to people who have severe disease or critical disease, can save their lives, can have a much positive impact on their outcome, but it needs to be administered to people who are severe and critical. It's not meant for individuals who have mild disease, and it's not meant as a prophylactic. And it's important that the right dose be given to the right person at the right time. And so for dexamethasone, it's for individuals who have severe disease and critical disease. It's not meant to be taken over the shelf, in pills or in an IV form outside of a medical facility. So I just wanted to highlight that there as well. So there's a lot that can be done for people at home, caring for them at home, and then also to look out for your mental health as well, because these are really challenging times and really scary times. If you have a loved one who is sick at home, do what you can, to provide the best care that you can. Good food, good amounts of liquid, and reach out to your loved ones.
Thank you so much, Maria and Mike. Here is the next question from. There's so many. Sorry, I'm just going back to the top ones first. Fiona Jones, watching us on Facebook, is asking, what are you, as WHO, doing to support these countries with surge in cases?
Well, there's quite a lot that's ongoing right now. First of all, throughout what we've been doing through our regional offices and our country offices is working with ministries of health and beyond the health sector to establish this all of government, all of society approach. The support doesn't start when there's a surge. It starts before that. And it starts, in fact, right from the beginning when we were first learning of this cluster of pneumonia and getting the systems in place. So we're supporting countries and best using that comprehensive strategy, which encompasses surveillance, first and foremost. Where is the virus circulating? Who is infected with this virus? And then how does the testing strategy match that to ensure that individuals who need to be tested be tested? We still recommend, this is a recommendation since the beginning of the pandemic, that all suspected cases, so these are individuals who are suspected of having COVID-19 or infection with the SARS-CoV-2 virus, be tested, and that those test results come back quickly, and that leads to public health action. So it's working with the governments to ensure that appropriate clinical care happens early in the pathway, that the workforce is trained, is protected, they have the right PPE. So it's about supplies, it's about training, it's about making sure that health workers are operating in a safe environment. It's about making sure that we have good drugs and therapeutics and the dexamethasone and the oxygen, medical level oxygen. I'm sure Mike will want to talk about this because this is absolutely critical to have medical grade oxygen and all of the supplies that are required to administer oxygen to an individual. So all of this is happening in a dynamic way of supporting through training, supporting through supplies, helping them with surveillance activities and reporting, and best using the capacities that they have where needed. So it's really quite a dynamic interaction that we have with governments. But it's a challenging thing to do for 194 member states. 18 months in, they're exhausted as well. So a lot is being done, and we're really grateful to all of our country staff and our regional office staff that are working so hard on this. Mike?
Yeah, we have 152 country offices, and our staff, those offices are just been incredible and working day in, day out with countries and providing that support. We've also sent hundreds of missions, emergency medical teams from the Global Outbreak Alert and Response Network, teams from the Global Health Cluster, which is a collaboration of all the NGOs and others who work in humanitarian settings. So we've really focused on leveraging the efforts of ourselves, but all of our partners as well, to give as much support as we can to countries, to the ministries of health and to others, NGOs inside countries. And we've done everything from helping to design isolation facilities and redesign hospitals, to providing direct provision of oxygen PSA plants, to delivering oxygen concentrators, to training. We've over 5 million people who've been trained within the open WHO platform in 36 different languages, which has all been directed. I think we're up to just 100 courses today within the open WHO platform. So a lot of our work in WHO is to set global standards, come up with global strategies, and every country uses them, we hope, and be that beacon of science and knowledge. But then for other countries, we try to give them access to specialist technical knowledge. So they maybe have a very good health system, but what they need is access to special knowledge, special consultancies. For many countries in a fragile, conflict, vulnerable setting, particularly in humanitarian settings, we have to provide much more direct assistance to the health system, much more involved, hands-on, and we do that as well. I'll be very frank with you though, we've suffered in the last couple of months. Last year we had much better funding than we have this year. Quite frankly, there's been a collapse in funding for our activities. Very hard to understand how WHO would lose financial support for its efforts in COVID-19. You can explain some of it by some of the negative politics that have been around, but the reality is, whatever the cause, we have much less money this year than we had last year in order to respond to this pandemic, and we are severely constrained by that lack. And even of the funding we've received, 85% of that is earmark funding. We're given the money on a specific requirement that it's spent in a specific country on certain activities. I have very little freedom. I think in the overall budget of $1.9 billion for our program in COVID this year, I think I have $50 million that is free to spend on whatever we need to spend. And when your listeners are saying, what are we doing for Nepal or India? And next week it was PNG or Papua New Guinea and Fiji, and then we're being asked to assist in Haiti, then we're being asked to assist in Indonesia or where other places. It's almost impossible. We have almost zero flexible funding in order to do it. We do our best to our country offices. We move money around. We rob Peter to pay Paul. We play the most amazing shell games in the world to try and support our country offices and ministries of health. And interestingly, in that, with all of the other partnerships out there, with all of the money that's sloshing around, in May and June, of all the oxygen concentrators sent to all the countries from the international system, WHO procured and sent 46% of all of those. We're still responsible for nearly half of the deliveries of oxygen concentrators in the world, even though we simply don't have the money to buy them. But we find a way. And I'm not saying to people you should go out and fund WHO. You should fund everyone who's responding to this response, but we should also be making sure that we're funding agencies that can deliver quickly and can deliver on the ground. We are genuinely struggling to meet the needs. Not technically, we have wonderful collaborating centres and partners, and we never have enough staff, but who does? But we are very severely constrained by a lack of operating cash to run our operations, and that's been the case now for months. But you know, it's very churlish of us to complain about that. We just keep working and keep using the resources we have to the best of our ability to deliver life-saving interventions and to help countries do the best they can. But I am very personally disappointed at the level of funding that we have received in this response, and I find this frankly shameful, but there you go. Donors make their own decisions about where they put their money. But it's really important that we think this through and try and at least fund the agencies that are trying to help countries in the front line.
Thank you, Mike, and thank you for clarifying, because the next question is from Urmil Katoch, also watching us on Facebook. How can we plan fast to control the next wave?
You got to be ahead of the game. You got to predict where the next wave is going to be. You got to, we know this disease is moving. We've seen it. I mean, it wasn't surprising that if we had the cases in India, that we were going to see surrounding countries like Nepal and Bangladesh and Myanmar have a problem. You know, it wasn't surprising if we saw cases rise in South Africa that we were going to see cases rise in Namibia and Botswana and Eswatini and Lesotho and Mozambique. You know, you don't have to be a science geek. You don't have to be an epidemiologist to work out if you're very, very close to a wave of the pandemic, the chances of it hitting you, it's like weather. You can't isolate weather, and that is the case. And so we do have a pretty good idea of how the disease is moving. The problem is it doesn't matter how slow moving tsunami is. If you can't get out of its way, then you're in trouble. And our problem is that health systems are just not funded enough, they're just not ready enough, they're not reactive enough, and they're not resilient enough to be able to absorb the pandemic hits as they come. And we seem to have collectively lost the ability to suppress transmission. And partly that's because we're seeing new variants that are more transmissible, but partly because many countries seem to be completely abandoning the idea that we have some control over this virus. And maybe people are putting so much faith in vaccination as a silver bullet solution that we're not using the solutions we had before. But the fact remains that for most countries right now, tragically, vaccination is not an option, or not an option that's going to control disease transmission. But we do have things that will control disease transmission. And we seem to be very much caught in the headlights that there's nothing we can do. It's inevitable that we're going to see these waves, and it's inevitable that the hospitals are going to fill up, and it's inevitable that the graveyards are going to fill up. It's not inevitable. It can be stopped, but it's going to take yet another effort from communities that are exhausted, from health workers who are exhausted, and it's harder and harder for everyone to pick themselves up. It would be so much easier to do that if people felt that they had the solidarity of the rich countries in sending vaccines. But right now, people feel a little hopeless. They've been left alone to deal with this pandemic alone, and they don't have the hope that vaccines are coming. The cavalry is not coming. And it's amazing how, in any endeavor in life, how much confidence and a sense of morale has to do when you're fighting in any situation for your survival. Morale is very important. And we really need to send a signal to the South. We need to send a signal to developing countries that the industrialized countries in the North cares. And we care enough to send vaccines. The cavalry is coming. And if we do that and we send vaccines and countries can pick up on their public health and social measures, put the two together, an effective, comprehensive strategy, there's an awful lot we can do to control the numbers of cases around the world, in every country. We seem to have become fatalistic, that it's almost inevitable, the next wave. You even said it, what are we going to do about the next wave? We're assuming it's going to be a massive wave in so many countries, because that's what we've seen in Brazil, that's what we've seen in India, that's what we've seen in Nepal. We're becoming accepting of our fate, and that does not need to be the case. It really doesn't. I don't know how to face it. I don't know for us all to turn back and face that reality. But I think there's a loss of hope. I honestly think that many people in developing countries have looked and seen, well, here we are on our own again. The world cannot find a way to share, and we're left on our own again. So we may as well all go back to work. No help is coming, and we will then take this punishment, right? I mean, I can't explain it any other way.
Yeah, I don't know. I can't remember if it was in one of these Facebooks or if it was at one of the press conferences where I answered a question. I said, there is no inevitable next step here. There is no inevitable aspect to this pandemic. It's what we make it. I think so many people want SARS-CoV-2, COVID-19 to have this predictability like flu. Like there will be a season, like we can just get through the summer in the Northern Hemisphere, then we'll prepare for the winter. Or if we could just get through the summer in the Southern Hemisphere, we can prepare through. This virus is not behaving this way. Maybe we will get to a point where there is a seasonality or there will be some seasonal patterns. Maybe that will happen. But right now, we're not seeing that. What we are seeing is we are allowing this virus to spread between people through this combination of factors. And this idea of having to prepare for a surge, to me, it shows how much we've failed in our ability to express the need to be ready, to be vigilant, and to build those systems now and to invest in those systems now. Because we haven't seen that in a number of countries. I'm asked, I don't know about you, Mike, in the interviews that I do, I'm asked every single interview I do, tell me the characteristics of countries that did well. What are the characteristics of the countries that did well? And what they did is that they've built systems. They have a surveillance system in place. It doesn't have to be the most sophisticated surveillance system in place. They have testing in place. It doesn't mean they have tests for every single person in the country all of the time, for the next 6 months. It means they use those tests that they have strategically, responsibly, and they link that test result to an action. What does it mean if somebody has a positive test result? Well, it means they get isolated, they get their clinical care, they are looked after, they are provided information, contact tracing takes place. Well, if it's too much and there's community transmission, it means cluster investigations, outbreak investigations are happening. And they say, how do I use these materials that I have to say, where is transmission occurring? Is it occurring related to a nightclub? Is it occurring related to a religious event or a mass gathering event or a long-term living facility or a health facility or a school or whatever it may be? Where is the virus circulating? If you know where the virus is circulating, you can target your actions. And then at the same time, give your health workers a rest if you can. Care for your health workers, get those supplies in for the PPE that they need, make sure that they are trained, make sure that they are working in a safe environment, they are protected from stigma and attacks in their home countries, at home, in the medical facility and out. Make sure you have community health workers that are doing contact tracing. It's building those systems now. And we're just not seeing that happen. We are not seeing countries now, high-income countries, with, you mentioned $50 million. $50 million, which maybe sounds like a lot of money, and it is a lot of money, but to cover 194 member states is pennies. Think about the national institution in your country right now where you're watching, how much money they spend on one program. I guarantee you it's more than $50 million. But we need to be able to use that around the world. And it's really frustrating. Sorry, you hear my frustration in this, but it's impossible to be able to prepare for us to be able to support the way we want to in every single country, which is why we rely on our partners, and we're so grateful for our partners to be able to do so. But there is no inevitable next step. The surge preparation is now. In countries that have transmission at a low level, they should be preparing now, because it will not only be good for SARS-CoV-2, it'll be good for the next one, because I'm afraid there will be. And the more that we can use this situation right now to prepare for whatever comes, that we can be ready for it, the better off we'll be.
Thank you, Bob. There's a lot of follow-up questions today. So I'll read the two that are on the same subject. Both LinkedIn and Facebook viewers are asking, is there an alternative plan to cope with the decrease in funding? And the second one on the same subject is coming from Carrie Hill de Cantero, watching on Facebook, saying most nonprofits have the same struggle staying nimble with lack of unrestricted funds. Mm-hmm. How can they band together to change funders, and how can average people donate to general funds?
I think it's tough for NGOs, INGOs and NGOs as well. They often get a lot of money, or what money they get is specified, and it is tough for them to also be flexible in our response. And the one thing you need in an emergency response is flexibility, because you can't program everything in advance. There are many ways to donate to NGOs, INGOs in particular. You have many ways online to be able to donate, and you should find and continue to support NGOs. Whether they work on COVID or not, particularly health NGOs do fantastic work around the world, should always be supported. And very often they can get more direct money into real projects at country level in a very efficient way. So my full support for all of that. What we try to do internally here in WHO is we try to shift a lot of resources into the response. We have a contingency fund for epidemics. We do internal borrowing, so we try to maintain our cash flows in the hope that money will come through. We have internal borrowing mechanisms, so if a donor makes a pledge, what we do is we can get special permission to spend that money before it arrives, in the sense that the pledge is from a recognized donor who always makes good on their checks, and then we can use internal funding that we have in a reserve, so we can begin to spend that money even before it arrives at the door. So we do everything to try and maximize how we get money out the door to the countries and to the field operations that we run. But there is many of the donors are funding there is a general lack of money in the entire global system for this response. If you look at the ACT Accelerator partners, Gavi and UNICEF have received a number of billions in order to buy vaccines, but that's all been choked up in vaccines. On the therapeutics and on the oxygen, the diagnostic side, I believe the Global Fund has a fund funded about $4 billion for the delivery of commodities to countries like oxygen, like diagnostics, and we're trying to support the Global Fund in getting those commodities ordered and out to countries. So that's another avenue that we've been trying to support them in spending the funds that they have received from donors. And WHO has recently set up a WHO Foundation, so it is possible to contribute funds. We ran a very successful solidarity fund for COVID last year, and we had over $250 million contributed into that, which was fantastic, and that was all of you out there, and thank you so much. Made a huge difference to the work we did. So the WHO Foundation is now formally in place, and if you feel like, and go there and donate a few dollars, but there's also a Get One, Give One campaign, Go Give One, where you can, when you get your vaccine, you can also go and donate something to make sure someone else gets vaccinated, and that's always a good thing to think that you're linking your action to something very specific. So there are loads of ways to support. I'm not trying to engage in direct advocacy here, Alex, because I don't really expect ordinary citizens who already have paid their taxes to be having to be sticking their hands in their pockets again to support WHO. We need our main donors and our member states to step up and support this activity. That's our primary source of funding. We're always glad to get direct funding from the public. We're not very good at doing that historically. We should get better, but we would hope that our core donors will step forward and really support us. And there are some fantastic donors. The government of Germany have been absolutely superb in supporting us right through this, and there are others. But so I'm not saying that all we're completely without people willing to invest, but there's been a noticeable drop off in the last year, and that means that we are paying a frontline price for some of the nasty politics that happened last year, and that's sad, but it's true, and that is the reality, and we have to face that. So we will continue to work. We'll continue to drive our performance as best we can. We're humanitarians at heart, and we will always find a way. The one thing about humanitarians, if they're NGOs, that they're here, we're activists in the same way, and we're activists within a system, and people look at the UN system and say it's bureaucratic and it's this and it's all those things. It's infuriating at times, drive you mad, but we're in here and we're trying to make it work, and we're pushing it every day to do what it should be doing, make it better, make it more efficient, make it more responsive to people's needs, make it more cost effective. Make sure I know that every dollar we get, somebody has paid in tax. Somebody has put that in a jar, or someone has paid that in their tax. That's a reality. And we need to make sure we maximize how we use people's money. And we need to be sure that it's directed towards the people we want to assist. And we know that. We've got people today working in Tigray in the most difficult of conditions and risk of their lives over the last 2 or 3 weeks particularly. And they continue. They put me to shame. Because I'm on a call this morning with Rob Holden, our team leader, and he's the enthusiastic one, and his teams are out there, and they're full of hope and full of the desire to do more, and we're the ones back here in Geneva complaining. So I would hate to think we're on a Facebook Live complaining about our lack of funding. It's always a problem, and sometimes poverty makes one somewhat efficient in how you use money. But the kind of poverty we have now is debilitating.
Ending on a positive note, I want to say something positive too, because where I sit in this pandemic, in my role as the health operations lead, I feel so privileged that we work, you hear me talk about this a lot, with so many scientists and public health professionals, medical professionals around the world who are giving us their time, who are giving us their experience, who are giving us the science and the knowledge that they're generating, the evidence, the data that they're generating every day to kind of drive this response forward, adapt where needed, adjust the guidance, review the guidance, translate the guidance, turn it into training, run those trainings. And this is an extension of us in many respects. I feel WHO, as we're a secretariat, we work with many different partners on the ground, we work with scientists around the world, and I feel like, my own team itself is an army of thousands in that sense, and I know we both feel really, really grateful for that, because that's time that people give us and give to this response, which is not paid, which is not something that we're giving when we have those teleconferences. The variants is one example, right, that we talk about. I mean, I don't know how many meetings I have every week discussing the variants, and clinical management, the variance in IPC, the variance in transmissibility, the variance in monitoring on the risk assessment. Where are they circulating? What is circulating? What is that specific mutation? What is that in vivo or in vitro study that somebody is doing in country A that is telling country X, Y, and Z? And that drives us forward. And I think that is one of the special superpowers that I think we as an organization have, to be able to harness the world's expertise on that. And the experience, because it's not just the data, it's not just the peer-reviewed publications, but it's that experience with a patient. It's the experience of doing that lab study that, advances our understanding. It opens up a whole new world of additional questions that we need to answer, but we have those collaborations in place. And it's a very special, privileged position to be in.
Yeah, there's probably hardly a country, we talk about everyone out there, you always name out all the countries at the end, which is always nice.
Yes.
But if you name any of those countries, there's not probably a country in which there aren't institutions in that country assisting WHO.
Yes.
So it could be, KEMRI in Kenya, or the UVRI in Uganda, or the Institut Pasteur in Senegal, or the Robert Koch Institute in Germany. We can go on and on and on. And Fiocruz in Brazil, and the Institute of Carlos III in Spain, and the hospitals and the centres. So people should feel, when they think about the World Health Organization, it isn't just a building here in Geneva. It is a massive collaboration of health workers, scientists, activists, and others around the world. We're working in health promotion, they're working in health protection, they're working in health response, in all of those different, and we're more than the sum of our parts. And sometimes we forget that too in Geneva. We often end up thinking that we're the center of the universe, and we're not. And it is that contribution from all of the partners that makes this organization have the impact it has, because truly on the budgets we have, we could never do it, but with that extra support from our collaborating centres, that really gives us the extra hands, the extra eyes, the extra arms, the extra legs that can actually get an awful lot more done than we do, and we are more than the sum of our parts. So, and Maria is right to recognise the role of our partner institutions, but don't think they're all in Europe, and don't think they're all in North America. Every single country has institutions collaborating to the Global Response Network. Yes. We've got 110 national laboratories, 120 now in influenza alone. So every country in the world nearly is contributing to global influenza surveillance. So many countries contributing, 250 institutions around the world in the GORN partnership. So it's incredible the level of solidarity there really is between scientists and NGOs and between institutions. We don't seem to quite have got there on vaccines, and that's a real tragedy. But if we could only translate the kind of solidarity we have in science and the kind of solidarity we have in cooperation amongst the humanitarian actors into similar sort of solidarity when it comes to vaccine production and distribution, then we could really make a difference in this COVID response.
Yeah. We need to expand the internet access. That's one thing I do notice, is given that everything now is virtual, we can reach anyone anywhere with an internet connection, and that doesn't exist everywhere. And so if we truly want to reach out, and Mike mentioned the Open WHO trainings that we have, we can do that in high bandwidth and low bandwidth, but we need to be able to reach. So I know there's some techies out there that are watching, and I know we have good collaborations with those that are trying to build internet and get more internet access around the world. We need further reach, I think.
Thank you both. There's still a lot of questions coming in. I'll try to summarize some of them. Maria, one is going back to the beginning when you were explaining the increase in deaths around the world. Mm-hmm. So some viewers were asking, do we know if there is a large portion, do we know anything about deaths among people who were fully vaccinated? And also then related to variants, several questions we received how the Delta variant is negatively impacting or has the potential to negatively impact people who are fully vaccinated.
So the Delta variant is one of the variants of concern that we are tracking around the world. And the Delta variant has demonstrated increased transmissibility. That is demonstrated through epi studies, through modeling studies, and we've seen that. When you have increases in case numbers, that can put a burden on the health system because you can have increased hospitalizations, and those hospitalizations, if it overburdens a healthcare system, that could result in deaths. We have not seen an increase in deaths in the case fatality ratio, the crude case fatality ratio, from the Delta variant, from any of the data that I've seen in different countries. There has been a suggestion of an increase in hospitalizations in some countries of people who are infected with the Delta variant. But that hasn't translated into increased deaths that I am aware of. But you have to understand that hospitalizations lag cases and deaths lag hospitalizations. So there are many studies that are underway that are looking at this. We do know that the deaths that are happening beyond the Delta variant, but the deaths that we are seeing, as far as I understand, is largely happening among unvaccinated individuals. And remember, less than 15% of the world is vaccinated right now, something like that. So the large majority of the world remains susceptible to infection. And if you have these variants, the Delta variant, circulating, people will get infected. And this virus is dangerous. This virus still can kill people, and it can kill people who are of an advanced age, it can kill people with underlying conditions, and it has killed people who don't have underlying conditions. So it is still a dangerous virus. We do need to do what we can to keep ourselves protected. But I do want to mention on the Delta variant, we know that the vaccines are incredibly effective against severe disease and death. That's important. So when it is your turn, get vaccinated. And if your vaccination course requires two doses, make sure you get both of those doses. But also, please continue to be careful. So we know that people who are vaccinated are protected against severe disease and death, but some individuals may be infected if they are vaccinated, but they are protected against that severe disease and death. So there's lots of studies underway to look at real-world use of vaccine efficacy and looking at what is happening amongst people who are vaccinated. There's very good news out there in terms of the protection against severe disease and death, even with the Delta variant.
But even within that, again, people need to be careful with statistics. Mm-hmm. Because let's say some of the mRNA vaccines show somewhere between 92 and 96% protection against what? Protection against severe illness and death.
That's right.
Okay, but that means if you take that as protection, let's say it's 95%. That means 5% are not protected, mm-hmm. and very rarely are vaccines 100% effective. So even if you are vaccinated, especially if you're only vaccinated once, you remain susceptible. But even if you're vaccinated twice, there are vaccine failures, and there can be any number of reasons why a vaccine fails to elicit a response. Some people don't respond mm-hmm. to the vaccine. Anything can happen. There can be any number of reasons why an individual vaccine doesn't work. But there is, therefore, if there's very high levels of transmission in the community and you've been vaccinated, you should still be careful. Particularly if you're older and have an underlying condition, because there is no absolute guarantee of protection. And that's particularly true in terms of getting sick, because we do know, particularly with the Delta variant, that there does appear to be higher levels of transmission. Mm-hmm. The vaccines still protect against hospitalization and death, but don't appear to be as efficient at protecting against transmission. So the virus, you could still become someone who gets infected. You may not even feel sick, and you may pass the disease on. So you become a vector of the disease. So it's important when we hear anecdotes, because I hear it myself. A lot of people say, "Oh, well, I know a guy who has a friend who has a cousin whose mother died after 2 doses of vaccine," and that may be true. But it's really important that we understand, is that because they had COVID, or is that because they were an older person who had a heart attack or had a stroke or died of natural causes. So we have to be very, very careful to really examine every case, and especially where there is a death in a fully vaccinated individual. It's really important that we establish whether that death was caused by COVID infection, mm-hmm. caused by another cause, and that's why it's so important that the follow-up of these failures of vaccine or perceived failures of vaccine are followed up carefully. And there's a lot of observational studies underway around the world to do that, exactly, because this is a really important issue. But again, I wouldn't be too concerned. If you are vaccinated, and you're certainly vaccinated twice against using, again, for those vaccines that require 2 doses, you are very well protected against being hospitalized or dying from any of the strains. So if you're in a high-risk group, if you are an older person and you have access to vaccine, please go get vaccinated. It's the best investment you could make. It is by far and away the most effective action you can take for your health right now and probably for the rest of your life in terms of avoiding something that's avoidable. And it's really important that particularly people in the older age brackets and people with underlying conditions take up that offer if they can to be vaccinated. There are some small number of individuals who can't be for different reasons, and that's fair enough. But it's important. And it's, you know, the countries who count vaccine coverage, you know, if someone says to me, I've covered 95% of my 25-year-olds, I'm not so impressed. I'd be much more impressed if people tell me we've covered 95% of our over 65-year-olds and 95% of people with underlying conditions. That's what that's how you're going to stop the hospitals filling up. That's how you're going to take the pressure off the health system. And it's a virtuous cycle, because if you vaccinate the right people with this vaccine all over the world, what will we see? We'll see a drop in hospitalizations, we'll see a drop in deaths, and because of that we'll see the hospitals empty, and because of that people's level of concern will go down, and because of that we may be able to return to something like normality. The problem at the moment is that vaccines are so unevenly distributed that countries don't have a hugely important tool in their armory. Maria keeps talking about trying to keep that transmission suppressed. And that's really important. We continue to do that. But we also have to try and protect people who are most at risk of dying. And it's very, very clear in this pandemic. It's absolutely clear in the data who is most at risk of dying. And if you're someone over 65 with an underlying condition and you get infected, you're hundreds of times more likely to die. Hundreds of times more likely to die than someone 20 years old with the infection. That's the reality. And we're leaving people on this planet with hundreds of times more likelihood of dying from COVID, unvaccinated, while we're busily vaccinating people who have a highly unlikely, if any, chance of dying from this. They still obviously could get very sick, and there are lots of other consequences we should manage. But the reality is that we're leaving people with a significant risk, and I mean a really significant risk of dying from this infection, and we're leaving them unprotected in this situation because of the decisions we're making globally. And that's why Dr. Tedros continually talks about the need to share vaccines and to share them now. Because, you know, we have enough vaccine on the planet. We have enough vaccine right now, this minute, if we decided, as a collective global civilization, as a global population, we have enough vaccine on this planet to protect every vulnerable person and to protect every person over 65. There is enough vaccine.
Thank you so much, Mike. Just before we end, given the vaccine inequity and the variant spreading, and on the other side, as Dr. Tedros is also saying about the two-track pandemic, we are also seeing that countries are opening up, easing their social and public health measures. We are seeing celebration gatherings being organized, some sports events. So in your opinion, is it too early for mass gatherings, given the pandemic, the stage of the pandemic and inequity that we are facing?
You're going to get her going now.
I think my opinion on it doesn't really matter. I mean, what matters is the context in which we're talking about.
Absolutely.
So the global situation is incredibly different. You know, there are countries right now that have controlled COVID and have gatherings, and it's perfectly safe. There are other countries that are having gatherings where the virus is circulating and it is not safe. So I can't give a short answer on that. What we are trying to do is we're trying to talk, and it links to what Mike was just talking about younger age groups and older age groups and vaccination. We're seeing a lot of social mixing around the world. And I'm not just talking about in Europe, I'm not just talking about in the Middle East or in South America. Globally, social mobility, the movement of individuals, whether this is within their home country or internationally, for religious reasons, for sporting events, for small gatherings. I saw a paper recently that was talking about birthday parties driving transmission. No matter what you do, if you increase the number of contacts that you have, and if it's done in a situation where you have low vaccination coverage, you have very few interventions in place, and it's not just the interventions at the event. So a lot of people are talking about Euro 2020, a lot of people are talking about the Olympics, a lot of people are talking about Wimbledon, a lot of people are talking about Copa America or pick an event. but it's all those other side events that are happening. I think all of us have seen the images of the fan zones and the people partying in the streets, and outside of the actual stadium itself, those are also massively at risk. The pubs, the streets, everything where people are really coming together. We know vaccination rates among younger men between the ages, I had to write this down, I was talking with my colleagues in Euro, between 16 and 45 in Europe, they have much lower vaccination coverage than women of the same age group, for example. We're seeing increases in transmission associated with events right now, and we can't sugarcoat that because we are doing things collectively that are increasing transmission again. So my answer is not a short one. It matters what we do. We advise a risk-based approach. We advise for an event to take place, a risk assessment be done. And if the event goes ahead, then plans need to be in place, provisions need to be in place, not just for the athletes or the speakers or whoever they may be at the event, but those who are watching it and for those side events as well. But you can't control everything that is happening. So policies need to be in place to be able to protect people, and you have a choice too. So we all have a choice about what we do and the decisions that we make and where we go. If we're not vaccinated, if vaccination coverage is low, and frankly, around the world it is far too low in too many places. Too many people do not have the vaccine or even have access to the vaccine. If we are taking measures that are helping to spread this virus, we are collectively adding to the problem. And what we need really is everybody to take decisions that help us bring us closer to the end of that. So, people need to ask questions as individuals. Do I need to do this? Do I want to? Yes, I understand that. I want to as well. But do I need to right now? And that's a hard decision to make because it's a sacrifice and it's incredibly unfair. And I'm not going to say that it's not. It's incredibly unfair. But our decisions have consequences. But we also need good decisions being made by everyone who's organizing, everybody who's going, religious leaders, community leaders, politicians. Everybody needs to be making the right decisions right now because collectively we just need to kind of get us closer to that goalpost, if you will, but we keep moving the goalpost, and so that keeps delaying the end of this pandemic. So, sorry, long-winded answer.
I think it's still possible to have I'm calling them mass gathering events, but gathering events. The real issue is where they're organized, how they're organized, and how much risk is taken out of the event, how much planned risk is taken out of the event. So if you take the example of the pilgrimage, the Hajj pilgrimage to Mecca, very, very important religious, cultural event every year. Well, the Kingdom of Saudi Arabia have decided, well, there'll be no foreign people will be allowed this year. Again, it'll be limited to a much smaller number of people who I believe will be mainly vaccinated. So they're trying to observe the gathering while keeping the risks to a minimum. I believe in the case of the Olympics in Tokyo, there are no foreign spectators coming. I believe very high rates of vaccination amongst the visiting athletes and delegations. I think they've decided on relatively low numbers attending the events, and there are no fan zones, and there are no pubs or bars, and people are being asked to go directly home after the events. Now, we can argue how much risk has been taken out by those measures, but what we want to see where mass gatherings are occurring, what we are encouraging and we are offering assistance all the time to organisers and governments is please think about the event in the context of your local transmission. Think about the event and who you're bringing to the event and where they're going afterwards. How much of the risk you can take out of the situation by testing, by vaccination, by measures to reduce contact between individuals, particularly between spectators and each other, and spectators and participants. And then how are you going to deal with the consequences of that? How are you going to monitor what's happening during the event to see if you have a problem or you don't? That takes a lot of planning. That takes a lot of investment. And just going straight back to huge gatherings without doing that, we saw a very successful return to many sports which were done without spectators. It took a lot of investment on behalf of those sports teams to be able to go back to professional sports, even amateur sports, by gradually managing the process. The difficulty now is we're back, and the big difference now is crowds coming to those games. It's not the risk environment for the professional athletes hasn't changed. If there are spectators attending the Tour de France this week and there were very few attending the Giro d'Italia a few weeks ago, Nothing's changed for the athletes. What's changed is the number of people attending a given event and how that risk is managed and how that density of people in any one place at any one time. And again, we come back to the idea way back months ago when we were talking about it, distance, duration, and intensity. We keep saying it. It was the amount of time you spend with other people, the distance away you are, how packed you are, and then the intensity of the activity you carry out. So if you happen to be in a fan zone in a country that has community transmission, and you're in a fan zone and you're there for 3 hours inside a closed roofed fan zone, and you're screaming and shouting and celebrating your team, and you're there with 1,000 people, and you're there for 4 hours, and there's virus around, then you are going to be exposed. Mm-hmm. That's a fact. Mm-hmm. So they're the issues. And again, we're back. Distance, duration, and intensity. And what we're doing now with some mass gatherings, and not necessarily the gatherings themselves, not the official gatherings. You can see that people are having, distance, and there's a limited number of people been allowed into the stadia. Some people have been tested before they come to the stadia. Some people are required to show vaccinations. There's different things being done. The problem I've seen over the last number of weeks in many parts of the world has not been occurring associated with the event. It's been associated with what happens after the event. And that's an issue. And we've seen many demonstrations of transmission being spread by that route, and that's potentially dangerous in the context of Delta variant. But that doesn't mean that you cannot host and have a gathering event, particularly a sports or religious event, that you can't do it safely. It can be done in relative safety if enough is invested in enough time to manage the various risks, and whether or not you have the consequence management in place, if there is a problem, to be able to rapidly adjust. And so therefore, I think you're right, I'm gone on too, but there's no yes or no answer. There's no yes or no answer. There's no all or nothing. No. Do we want to go back to having gathering events and seeing sports events? Of course we do. Mm-hmm. Do we want to see all the things we love to watch in the summertime cancelled? No, we don't. But doing it safely requires responsibility, requires planning, it requires investment, and it requires everybody involved, including spectators, to understand that it's about the sports event. It's not necessarily about the 4.5 hours in the bar afterwards.
I thank you very much. I know you're running out of
time, but
we can keep going.
No, there have been a lot of questions, but just one last, I promise. As Maria, you mentioned as well mobility, and I mentioned at the beginning of this conversation that we issued a travel guidance. So if you please can summarize what are the key recommendations and what do individuals need to know about traveling in time of COVID?
I mean, it's actually very similar in the sense of the elements related to what we were just talking about with mass gatherings. So it's taking a risk-based approach, and it's minimizing the opportunities for exposure, the opportunities for risk through the whole part of travel, for when you leave your house, through whatever mechanism by which you travel through your destination. So we've issued an updated guidance. It's actually not new, it's an updated guidance in there about outlining the elements and the considerations for governments to take those decisions in setting those policies. We still recommend travel for essential reasons. We really need to prioritize travel for essential reasons. Medical personnel, for example, making sure that we can get supplies around the world. We're still working on making sure we do that. We give advice on, how to, in countries of origin, through countries of destination. There's some information in there on the use of testing, for example, and how to set those policies related to testing. But it's a risk-based approach. And it's what we're trying to do is we're trying to support governments around the world to take the best decisions based on their risk, based on the risk that they have, the risk they perceive, their capacities to be able to respond. You can remember we're an organization of 194 member states around the world. So we work with high-income countries, we work with low-income countries, we work with island states, we work with, everyone, everywhere. And so setting those, there is no one-size-fits-all in travel. And the other thing is we do not recommend vaccination as a requirement of travel. And that's also really important. That comes back to the vaccine equity issue because the world does not have access to this vaccine, but that is also reinforced in this guidance. What else am I forgetting?
I don't know.
I think
you will find some regions, or some multi-country regions like the European Union trying to put in place arrangements to allow citizens to travel back and forth. So in that sense, it's a bit like the United States has 51 states, so the European Union is trying to organize itself so that there's a bit relative movement inside according to some basic rules. And you're seeing that more, you're seeing that similar arrangement, although it's not happening right now between New Zealand and I think Australia and others. So you'll start to see countries close by each other try to make arrangements to allow some movement. So no one is saying it's not safe to go on some kind of a holiday or a trip. What we're trying to say is that it's not the time to completely open up that process, because the actual act of travel has been very much de-risked. There's a lot of testing, there's a lot of work been done on ventilation on planes, there's a lot of work, people are still wearing masks on the planes. So the actual act of traveling on the plane is, although we've seen instances of transmission on airplanes, overall it's a safe mode of travel, even from a COVID perspective, given all the checks that are in there. The problem is what happens when you arrive in your destination, what you're exposed to, and then potentially what you bring home. And that's something that is difficult to manage. So if you're traveling from one area to another, from a low incidence to a high incidence area, particularly where there's circulating variants, the chances are you could be infected and you can bring that disease back with you. There's less likelihood of that happening if you're in a testing regime. There's less likelihood of that happening if you're vaccinated. So each country then will make its own arrangement based on what it considers to be the best way to manage the risk of importing disease. And many countries are now concerned, particularly with the emergence of variants, that they don't want to import too many cases of new variants, because as we've seen, when that happens, the disease can get out of control pretty quickly. So no one wants to shut down their borders, and yet nobody wants to import more disease than they need to import, or export more disease than they need to export. So again, it's a matter of being smart and asking yourself the question, do I really need to travel? And where you're traveling to and from, because maybe inside a European environment, traveling from Switzerland to France is fine if there's an arrangement between the two countries. But if you're traveling long haul between two far distant places, do you really need to do that long haul travel? And have you really looked at the risks on both sides? And are you increasing your risk by traveling there? And are you increasing the risk at home to others by traveling back? And in some cases you're not. In some cases it's perfectly safe to go on your holidays. If you're going to a desert island, maybe. So again, it comes down to, we would like to get back to normal, but the normal we're getting back to, where everyone thinks that we can just go back to just doing everything as we've done before, I think this has been very premature. I think overall we've made a very premature rush back to full normality. And I think we're going to pay a price for that, because we're not there at vaccination. The variants are really there, and we haven't protected enough people. And I honestly think that we need to think our way through this, that we're opening up way too quickly for the epidemiologic situation and the risks associated with that. We just need to be a little more patient. Remember last summer where we had everything got good, and then everyone kind of relaxed, and then we kind of arrived in September or October and ended up in huge trouble. Well, I think that's where we're going again, with a much more transmissible variant this time around. And that's the issue.
And it's not theoretical. I mean, we're starting to see it already. We're starting to see those increases already. So this isn't a theoretical what if kind of situation. So let's see if we've learned, more. We just don't, you don't want to see us here, a year from now having this conversation.
I don't want to see us a year from now having this conversation.
We do need to be careful. I do want to mention one other thing with these variants, right? So it's the Delta variant that everyone is concerned about right now. But there are 4 variants that are circulating. The Delta variant is more transmissible than the Alpha variant, which was the most transmissible before the Delta variant arrived. The virus is still evolving. There will be more variants. And variants mutate, become more fit, and they will become more transmissible, because that's what they do. They're not alive, they don't have a brain, they're not thinking about this, but they're evolving. And so we are expecting to see more variants come. That is not to strike fear, it's not, but it's a reality. More increased transmissible variants without the vaccine coverage reaching the levels that we need, it's a dangerous situation. So let's course correct right now and see if we can turn the corner and make sure that those trajectories going up start coming back down.
I thank you very much. We are over time. We took more of your time today than usual. So thank you for that. I thank all our viewers for great questions, and I apologize to those who We didn't respond today, but we'll do our best to respond to you next week or in some of our sessions. Please stay with us and visit our website for more information if you need them. And please stay safe following what Maria and Mike just said. Thank you.
Super.